All right, I'm here today with Marianne Starks, one of the first nurse practitioners I met. We met at coffee hour, I believe, at Bethesda Lutheran Church back when I was a music director in Connecticut. Um, she was one of my inspirations to go to nurse practitioner school when I was 35. I'm now engaged in organizational leadership among nurse practitioners here in California, and I'm going to Norway to share some of my experiences with the American nurse practitioner profession. And I wanted to ask Marianne a few questions about her very interesting nurse practitioner career. Marianne, first, tell us about why you decided to become a nurse practitioner.
So I was a nurse working in a community health center in New Haven, Connecticut Mental Health Center. And my director of nursing was Martha Mitchell, and she was a faculty member at Yale School of Nursing. So I'd been in nursing quite a few years at that point, 10 actually, and wasn't really thinking about graduate school until she sort of said, you should really consider graduate school. I was at the time of a head nurse on a psychiatric research unit, which was pretty exciting in and of itself. But she convinced me to try. And at that point, I always had this dream of running a clinic by nurses rather than working for doctors, because in the 80s that I was working, definitely the doctors were the ones running the medical units and the psychiatric units. So that was my fantasy. I think between her pushing me and my desire to do something specifically for nursing, I got into Yale School of Nursing. And then, so that was really the only reason I got in, was because someone had said, you should do this. And I was grateful that she pushed me.
Yeah, that is very much like my own story. So you said you went to Yale School of Nursing. Can you tell us a little bit about the training that you received there, the specialty training?
I would say that what really was good about Yale School of Nursing for me, and I think it's changed over the years, you went to the Geppen program, which I think is different. I was a nurse already, so I went to the graduate level immediately. And in the 80s, the research piece was the one that sort of intrigued me the most, although I never did do research, but it pushed me to look further beyond my immediate experience of practice into what is good practice skills, what are things that we need to do in therapy, and to always look beyond, never feel like you've got it all. You need to always keep pushing yourself. So I would say that was the most important thing. I did my clinical practice at Connecticut Valley Hospital, which I remember the first day I went there, I actually almost vomited because it was just so overwhelmingly intense. And then I got into it because it was really a good experience in terms of getting to treat schizophrenics in a very intimate way and a long-term way, which you don't necessarily get in hospitals anymore. So I think that it gave me a good grounding in terms of my private practice. I had already had, though, a good grounding from my my undergraduate experience and early experiences working at the VA hospital in Connecticut, because I had really pushed to sort of learn how to do group therapy, and I pushed to learn how to be a team leader and that kind of stuff. So I'd always been pushing to do more, and I had a really good psychologist who helped me learn quite a few skills around group therapy, which was good for me. And then I worked on a locked unit at the VA, and it was like learning psychotherapy 101. It was just we had a group sort of supervision right after every meeting that we had. And so all the psychiatrists, all the psychologists, the social workers, the nurses, everybody met and would hash out like what were the dynamics of what had happened in the meeting. So that was almost better training than what I got at Yale, but Yale sort of expanded on that.
So the Psychiatric Nurse Practitioner program, my understanding is it's a combination of learning pharmacology and management of medication and also doing therapy. So it's kind of both skill areas. Is that correct?
I would say that that's true. I think that when I was there, the pharmacology program was not as emphasized as it is now. Um, um, when I first started being a clinical nurse specialist, which is what I graduated to, we weren't doing the meds, except we would write a script, but then the doctor had to sign it. So we didn't really have that as part of our practice. And really what I was doing was evaluations and treatment and group therapy.
When did that change, venturing into prescribing medication on your own? And what
So
was the path to
probably,
that?
yeah, in around the 90s, somewhere in the 90s, the law changed that we could have prescriptive authority. And once that happened, it really shifted my practice into primarily being medication management, but I maintained an interest in doing psychotherapy as well. So I always had done that in my private practice. So I did a lot of psychotherapy, individual and couples and group, along with medication management. Whereas I think a lot of my colleagues shifted over to just doing medication management.
How was your collaboration with psychiatrists in that early phase of the career when you were getting into prescription, etc.? But there was not yet independent practice in Connecticut for nurse practitioners.
Exactly. I mean, I think a lot of the doctors saw us still as assistants to them.
Mhm.
I think once we became truly independent, there was a lot of resistance to letting us do that. I mean, it was, I
It was
think there
radical.
still is resistance to letting us do that. I mean, they shifted yet again. Like once I got into independent practice, of course, I had years already, being somewhat independent. But now they require, I think, nurses to have, I think it's 3 years of supervision under a doctor, even outside of school. Is that correct?
Yeah, that's pretty common in many American states to have 2 or 3 years of collaboration with a physician out of nurse practitioner school before you can apply for an independent license as a nurse
Right,
practitioner.
and that's relatively new. So, mhm.
How before you had that independence, did you have a psychiatrist connected to your practice that you would
We
review
did.
cases with?
Yes, we had a psychiatrist that I had worked with at the VA, and he basically did group supervision with a couple of other nurse practitioners besides me, and so we would discuss cases with him and with each other. It was I thought, very good to be able to do that.
Great. And then when did you first have your own total independent practice where you were prescribing, etc.?
I think in the early 2000s was when I really started doing, maybe no, it would have been, so I'm trying to think now. It would have been probably maybe 2010
Hmm.
that I would have actually not needed a psychiatrist. And I
Hmm.
and I think we ended that. We tried to continue though the collaborative discussions because those were valuable to us in terms of our own supervision of our practice.
Were there ever cases during your independent practice where you felt like it would be good to have backup and you reached out for support from that psychiatrist or others? Or?
We didn't feel like that particular psychiatrist was helpful. We
Mhm.
did reach out to some um, psychopharmacologists because they would have specific knowledge about pharmacology.
But
And
for the last few years of your clinic, you basically were running your own business, seeing your own patients, doing therapy and prescription management for them.
yes,
And what kind of patient population were you seeing?
Um, I I really had a rich variety. I had schizophrenics, and I had depressed and anxious people, and I had um, people from every sort of background. I had a woman who was from Japan, and I had um, a couple of other people that were from other countries that were really interesting. I had a men's group. I had a two women's groups that I continued to run. Um, I had a variety of kinds of patients, I think, from clinical, cultural, and economic backgrounds. I
And you
also
mentioned,
practiced private practice in Darien, which was very different than my practice in Hamden.
Mhm.
Just economically, it was a very different group of people.
Yeah. One of the great things that has helped the nurse practitioner profession grow in the United States is the focus on increasing access to care for patients from difficult socioeconomic backgrounds, etc., who didn't have adequate access to physician care. It sounds like some of your practice also contributed in that area.
Well, I took Medicare and Medicaid. So
Mhm.
that, I mean, as well as, private insurance and self-pay. So yes, that helped to diversify, I think, my practice a lot.
And you also manage complicated depression and bipolar disorders, etc.
Yes.
I'm familiar with. Hey, Marianne, I wanted to add on one more question about your practice areas. I heard that you did some work together with a psychiatrist supporting nursing homes, which is a potential big area for nurse practitioners in Norway. Can you tell me a bit about that?
So I was working with a psychiatrist at Griffin Hospital in the outpatient clinic. And we contracted with all the area nursing homes to do assessments and education to help them deal with the sudden influx of a lot of psychiatric patients to their system, which they weren't prepared to manage well. And patients were either getting over medicated or they were simply getting re-hospitalized constantly. And so through our work, we really did help them to learn how to manage these patients and decrease the sort of um, rotating door at the hospital, which I thought was very helpful.
This was during the time after a lot of psychiatric institutions were closed down.
Right,
So,
it was post deinstitutionalization. I mean, so, that had happened quite a few years before, but people were being shunted then to hospitals, I mean, to nursing homes and to jails and other places because they weren't properly treated out in the community. There was, small community health centers, but they were overwhelmed and didn't provide the things that they really needed, which was housing and jobs and structure, which they had probably gotten in the institution, but then they went out into the community and didn't have that. But then they were then, because they needed housing and they needed all these other things, they were just shunted into nursing homes and jails. So I felt like our work at the nursing home was really important in terms of providing some of what they needed from the nursing home without having to go back into the hospital.
all right. Well, thank you for taking some time to describe your psychiatric practice. This doesn't exist yet in Norway as a nurse practitioner area of practice, but I think it'll be very interesting to share your experience with my colleagues over there who are currently focusing on the adult general nurse practitioner role at this time,
What
both
what
in
is the role over there?
they are calling it general practice. So it's similar to our family nurse practitioners and acute care nurse practitioners, in terms of the training. And they're just developing roles, developing partnerships, looking at what it might look like to prescribe, which is not yet a possibility with their laws. So hearing the United States experience, I think it's important and useful information as they go through that process. So I'm looking forward to sharing some of your story with my colleagues over there.
I appreciate having the time with you.